questions or need to chime in. I'm EJ Priholis. I'm one of the geneticists in Columbia. And today's talk is going to be on congenital anomalies. Really, this is a chance, I think, for us to talk about different ways to think about birth defects and evaluations. So the objectives, we'll talk about birth defects in terms of different terms: malformation, syndrome, association, dysplasia, sequence, disruption, and deformation. And just recognizing that some of these might be related to genetic components. Some of them may be environmental. And so we'll be able to discuss some examples, and hopefully you can recognize some of the examples of each. So congenital anomalies are structural abnormalities of prenatal origin that are present at birth. And they can be external, so easily visible, internal, and may needing some additional imaging to identify, single, meaning isolated, multiple birth defects affecting one individual, major or minor, familial or sporadic. And this is an example. It's a single birth defect, and this would be an example of amniotic band. So a single defect affecting one limb, or the foot, with some areas of constriction bands that give you evidence for amniotic band, and sometimes they can also have syndactyly. And then in terms of multiple with different chromosomal abnormalities, you might see certain limb defects, as well as identification of internal abnormalities involving the head, heart, or abdomen.
The geneticist.
All right, so again, an example of external, something like cleft lip, or internal, like tetralogy of Fallot, where you see some of the abnormalities, the VSD, the pulmonic stenosis, the overriding aorta, and right ventricular hypertrophy. They can be minor, like a single transverse palmar crease, which individuals can have on their own. Sometimes children might have these, and you just take a look at the parent, and the parent also has this, and they're healthy. And then a major birth defect, like a neural tube defect. As we talked about, familial versus sporadic. So familial in this pedigree, just demonstrating multiple generations that are affected by a condition, multiple generations, male-to-male transmission, both females and males affected, suggesting a dominant condition, versus a pretty clean pedigree with one proband who is identified. So the importance, or the reasons that congenital anomalies are important to recognize in pediatrics, we know that birth defects affect 1 in every 33 babies. That's about 3% of all babies born in the US each year. And they are a leading cause of infant deaths, accounting for about 20%. And when we think about the causes of birth defects, there can be various causes, many of which are unknown. So if you just think about in general, about half of birth defects we may not know the cause. Approximately 20% have a chromosomal cause, 5% may be caused by a teratogen, and 25% may be related to a single gene disorder. And so the pattern, again, can be sporadic, just by chance this occurred in an individual, can be part of a syndrome or other kind of pattern, like a multifactorial pattern. So the definition of a malformation is a structural alteration that occurs during the prenatal period, specifically during organogenesis. And sometimes they might be related to a multifactorial condition or as a multifactorial trait, meaning that this is a result from the interaction of multiple genes and environmental factors. And so when you think about multifactorial conditions, this is a condition where the risk to family members is greater than the population risk, but lower than the risk for a Mendelian condition or Mendelian trait. So not something that would have an autosomal dominant pattern of inheritance with 50% recurrence, or recessive recurrence at 25%. So lower than that.
And
And
Maddie, I guess.
the things that might contribute to the recurrence risk numbers might include the severity of a condition, the degree of relationship of which family members are affected, the number of affected family members, whether that individual is male or female, the age of onset, and if there's history of consanguinity in the family. And multifactorial disorders, we think about some of the common adult onset conditions like diabetes, hypertension, or coronary artery disease. But some of the congenital anomalies that we think of as being often multifactorial in pattern are cardiac defects, things like cleft lip and palate, and neural tube defects. So neural tube defects or neural tube defect is a relatively common disorder occurring in 1 to 3 per 1,000 live births. And just remember that it's at 18 to 28 days after conception, the spinal cord of the embryo begins to flatten and rolls into a tube. And when this doesn't occur correctly, a neural tube defect can happen. And this are various degrees of neural tube defects. So spina bifida occulta, this really doesn't or shouldn't cause any major issues. It's more of a radiologic finding where the dorsal vertebrae are not as well formed. And then with a meningocele, this type of neural tube defect, you see a cystic lesion, but no neural tissue. And then the myelomeningocele, where the neural tissue is involved in that cystic abnormality. And we think about neural tube defects, and everyone's heard about folic acid and its contribution to helping prevent neural tube defects. So any woman who is planning to have a pregnancy, or fertile women are suggested to have folic acid supplementation beginning prior to the conception and continuing throughout the first trimester, which is known to help reduce the risk of neural tube defects. And those individuals who've had a child already with a neural tube defect, their supplementation with folic acid is suggested be increased to 4 milligrams versus the 400 micrograms in those who have not had a child with neural tube defect or are felt to be at risk. And just remember, neural tube defects can be identified on ultrasound at times, as well as maternal serum AFP is elevated. in, like we said, another type of condition that is often associated with a multifactorial pattern of inheritance is cleft lip and palate, or when we think about isolated cleft lip and palate, certainly this birth defect can be associated with things like chromosome abnormalities or other genetic disorders, but again, most often isolated and multifactorial. And just some depictions of types of changes you might see. So an individual who just has the cleft lip involvement and some of the alanae, and then here a little bit more involved with portion of the gum involved. And bilateral cleft lip, you can see here with full palate involvement in this bottom slide. So in terms of development, it's by 7 weeks the lip is normally fused. And at times the failure of the lip fusion may impair the subsequent closure of the palatal shelves at 8 to 12 weeks. So remember, all of this stuff is pretty early in pregnancy. And then other things you might identify in a child as they grow with cleft lip and palate include difficulties or problems with tooth development, incomplete growth of the alanae. So sometimes you see this splaying of the nair. And oftentimes we might recognize that children with cleft lip and palate may have wider spacing between the eyes. And so with all of this,
I think it's a parasite, so I guess I would say maybe false.
Somebody's.
Y'all mute your mic. I think it's Dalton.
All right. And then just to review, so again, most of the time, cleft lip and palate is isolated, and people ask questions about recurrence. Recurrence risk based on whether cleft lip and palate is based on whether you think this is isolated or associated with a chromosome abnormality or a syndrome. And for those with isolated cleft lip and palate, usually the general figures or empiric risks we give are a risk of 4% if an individual has a cleft lip and or palate. If there are 2 children involved, that empiric risk is raised to 10%. And then if an affected parent and a child are identified with some variation of cleft lip and a palate, and again, a syndrome is not recognized or a specific cause is not recognized, that empiric risk is 14%. Just a depiction here, just to let you know that cleft lip and palate can sometimes be identified on prenatal screening, but not always. And oftentimes individuals may be offered chromosomal studies to look for potential aneuploidies during a pregnancy if they see abnormalities or multiple birth defects on the prenatal ultrasounds. So again, we talked about mostly isolated findings with cleft lip and or palate and neural tube defect, and we'll just talk about syndromes a little bit. So a syndrome is a particular set of features that occur together repeatedly in a consistent pattern, which implies a common cause or etiology. And I put this up here, van der Rohe syndrome, because it is the most common clefting syndrome that we think about. It is characterized by cleft lip and or palate and these lower lip pits. It's an autosomal dominant condition with kind of, you can have different expression in individuals who have an IRF6 gene mutation. So it's really important when you have an individual that you find with a cleft lip and palate to ask about family history, about any minor features of cleft, as well as lip pits, because that is a big clue that this is part of a genetic syndrome rather than a multifactorial cause for cleft lip. All right, and then 22q11.2 deletion syndrome, I put up here just for you all to be reminded about cleft palate or bifid uvula being a sign or feature that can be a part of a syndrome, specifically 22q11, and that it may be important to look for other potential congenital anomalies that are associated, including congenital heart defects. These individuals can have some characteristic facial features, although you can tell in this photo with individuals of varying ethnicity that sometimes it's hard to pick out all of these things. But the longer tubular nose is characteristic. Sometimes a bulbous nasal tip and ear anomalies are evident. These individuals can have learning difficulties and developmental delay, immune deficiency, absent thymus, low calcium. And then again, just moving on through some syndromes that can have multiple birth defects. We'll move through these quickly. As many of you know about the common trisomies, including Down syndrome, where individuals can have hypotonia, poor feeding, excess nuchal folds, tongue protrusion, ear anomalies, and characteristic facial features that are noted in the newborn period. And about half of children with Down syndrome have a congenital heart defect. And so getting that cardiac evaluation is important.
When you do this method, one of the key things is you gotta
And then this is a photo or picture of an individual with trisomy 18. And just remember some of the characteristic features that might be evident, including ear anomalies, micrognathia, as rocker bottom feet, and a clenched fist. And then trisomy 13. Oftentimes I think about congenital anomalies, including midline defects that can include cleft lip and palate, holoprosencephaly, polydactyly, oftentimes post-axial, meaning on the pinky side. And just again, the list I have here to kind of differentiate some of the characteristic features of trisomy 13 versus trisomy 18. So again, 13 being some of your midline defects, colobomas, cutis aplasia in the scalp, and then with trisomy 18, as you saw in the pictures, that the clenched hand or the clenched fist, the prominent occiput, and the micrognathia, and they tend to be small for gestational age. All right, moving on to craniosynostosis. Again, a syndrome that may be recognized in terms of anomalies of the facial features and potentially extremities. So craniosynostosis is premature closure of one or more of the cranial sutures before brain growth is complete. And treatment often involves surgical consultations and potential cranial molds. And this is a depiction of the cranial sutures and what you might expect when you see fusion in some areas. So again, this is the normal depiction of the skull if you're looking at it from overhead, and the anterior part of the head and the posterior portion of the head, and your typical or your anterior fontanelle depicted here. So when you have early suture closure, so for instance, here, the metopic and the sagittal sutures have fused. What you see is kind of narrowing, or the skull doesn't grow wide, but instead kind of grows long, long where the sutures are open, and kind of narrow where the sutures have closed. And again here, so the coronal sutures have closed early, and so doesn't allow for this growth anteriorly. So you have more of a shortened kind of head size from front to back, and wider from side to side. And then here, not a birth defect, but more of a positional plagiocephaly. All the sutures are open. And these are photos of a child depicting Crouzon syndrome. It is one of the most common of the craniosynostoses, often with bilateral coronal suture closure. And oftentimes, like I said, so the growth isn't able to occur as much from front to back. And so you can see these mid-face abnormalities, and the orbits appear shallow and the eyes appear prominent. Approximately 30% have hydrocephalus. So again, something to look out for in these individuals who you suspect have craniosynostosis. Some of the other craniosynostoses have typical limb abnormalities, but Crouzon syndrome usually we think of as having normal hands and feet. And this is caused by a change in the FGFR2 gene. And then I bring this one up. Apert syndrome is one that I think is craniosynostosis that is recognizable because of this syndactyly of the fingers, or this mitten glove appearance, along with the craniosynostosis that causes more of a tall forehead with brachycephaly. And then Pfeiffer syndrome, again, another craniosynostosis, often also associated with bicoronal craniosynostosis, and the typical facial features, but there is some variability. So you might see different shapes of the skull, some that are described as a cloverleaf skull, some turibrachycephaly with that tall but shortened appearance of the skull. And these individuals can have characteristic broad thumbs and broad great toes. So again, clues to help figure out which craniosynostosis is most likely. All right, so going away from those types of condition, we'll talk about dysplasia. This implies disorganization of cell structure, disordered cell arrangement in tissues, and faulty tissue organization in an organ or morphologic feature. So this would include things like skeletal dysplasia or ectodermal dysplasia. And just a typical features of a child with achondroplasia, with this tall bossed forehead and a depressed nasal bridge, and the shortening of the limbs where you see extra skin folds. Again, an autosomal dominant disorder characterized by abnormal bone growth with short stature, disproportionate short arms and legs, and a large head. And some of the radiographic findings that can be clues include a large skull with a small foramen magnum. Sometimes you can see specific changes on the spine, as well as the pelvis. So the radiologist may read things about the interpedicular distance between the vertebrae, as well as characteristic features of the pelvis and short and long bones. And achondroplasia is associated with a particular change, most often in the FGFR3 gene. Most individuals with this condition have new mutations, meaning that both parents are unaffected, and this was a new change that occurred in a child. But of course, we do see individuals with achondroplasia who have children. Again, it's an autosomal dominant disorder. An association, so moving on from the conditions that we know have a little bit more of a specific genetic cause or syndrome. An association is a non-random collection of two or more features seen together more frequently than expected by chance. The link is not strong enough or consistent enough, however, to be a syndrome, and no specific etiology is identified. So one of these examples is Bacterial or Vater association, and we all know that this is an acronym for vertebral anomalies, anal atresia, cardiac anomalies, tracheoesophageal fistula, esophageal atresia, radial and renal defects, as well as limb defects. Again, all of this is felt to occur, or issues with these areas are to occur very early during embryonic life. And here's just an example of a child who's believed to have Bacterial, and you can see the radial anomaly here. And then there is another condition that we think of with overlapping features of Bacterial, and it's OAV spectrum, or oculoauricular vertebral spectrum. And this is part of a spectrum that includes Goldenhar syndrome, and that's, again, we don't know the cause, but it was early on designated as Goldenhar syndrome. Hemifacial microsomia, which includes microtia or small ears with mandibular hypoplasia. And they can also have cardiac, radial, and renal anomalies. Usually intelligence is not affected, and it's typically sporadic. And this is just a picture of a child who has Goldenhar. And as you can see, she has this epibulbar dermoid, as well as the ear anomaly with this protrusion of the ear and the ear tag, as well as mandibular hypoplasia on the left, or on her left, I should say. And then sequences, disruptions, and deformations. Again, these are more of things that we might see as birth defects, but not necessarily associated with a particular genetic condition or genetic syndrome or gene known to be the cause. So a sequence is a pattern of anomalies that results from a single primary anomaly or single mechanical factor. And one example is the oligohydramnios sequence. And here, this is just a reminder of what you might see. So oligohydramnios could be related to a defect in urinary output from a fetus. It could be related to chronic leakage of amniotic fluid during the pregnancy. But all this may result in growth deficiency, fetal compression, and pulmonary hypoplasia. And what you might see are Potter's facies in the baby or fetus, as well as limb positioning defects. So again, just another kind of depiction of what might be seen with relatively lack of amniotic fluid, resulting in pulmonary hypoplasia and respiratory insufficiency, or fetal compression with birth defects that might be recognized as altered or anomalies of the face and abnormal positioning of the extremities. A disruption is the result from disruptive processes that alter structure after formation. And usually this is environmental. This can include compression, adhesions, or amniotic bands. This may be the result of loss of blood supply, or sometimes could be related to genetic causes associated with program loss of blood supply, but still some of those are very difficult to identify. Again, what you may recognize are luminomalies related to amniotic band. And so again, here you can see this little constriction ring, or imagine this little constriction ring around the thumb. And then here, evidence of the constriction bands. And deformation. This indicates distortion or molding of an otherwise normal part through mechanical forces, usually acting over a prolonged period of time. So what are some examples? Usually these occur late in gestation, involve musculoskeletal tissue. Causes may be abnormal positioning, like breech positioning, or intrauterine constraint. That can be associated with fibroids or bicornuate uterus in mom, multiple gestation, or twinning, or triplets, or oligohydramnios. Usually, if it's primarily just a deformation, these can be reversible postnatally. So examples would be things like bilateral calcaneal valgus. So again, an example after prolonged low amniotic fluid, the foot could be abnormally positioned, and after birth you may see this, but you're able to move the foot to normal position, as well as clubfoot or Tilipes equinovirus. And metatarsus adductus, where the toes are medially deviated, but again, can be moved to more neutral position manually. Okay. Got any questions so far? Just a few more minutes. You're doing okay? All right. So this is a chance to just review some malformations and look at associated syndromes. And so here I just have a list of cardiac defects on the left and conditions or genetic changes related to syndromes on the right. So for tetralogy of Fallot, what is the condition that is associated with that one? Can I get anyone to volunteer? How about
22.
Yep, 22. Perfect. AV canal defects.
Trisomy 21.
Perfect. Trisomy 21. Bicuspid aortic valve. Turner, or 45X. Supravalvular aortic stenosis.
Williams.
Great. And that is caused by microdeletion on chromosome 7. And then pulmonic stenosis. It leaves you with this one. Does anybody know what that gene is associated with?
Is that Alagilles?
Not Alagille, but you can see pulmonic stenosis with Alagille. So this one is a condition with short stature. Some people might, short stature, wide space nipples, web neck.
Noonan.
Noonan, great, good job. All right, so we got them all. Okay, with these birth defects, which trisomy are you suspecting?
Trisomy 13 is hollow brachycephaly.
Right, good. And then this one. Perfect, good job. All right, now what do you see?
Coloboma.
Yep, so a coloboma of the iris here. It gives a keyhole appearance. And then just to review, this is an iris coloboma. It's a segmental ocular defect, arises from defective closure of the optic fissure during the 6-week post-conception. So again, very early. Can be limited to the iris, but can also involve the retina. It can be isolated or associated with a chromosome abnormality or syndromes. So anybody know of any syndromes that are related to colobomas?
Charge.
Yep, that is the typical one we think of. So CHARGE syndrome, an acronym for colobomas, heart defects, atresia of the choanae, retardation of growth or development, genitourinary defects, ear anomalies, or deafness. It is caused by a mutation in the CHD7 gene. And just some photos of individuals who are described with CHARGE. And this is, I put this in here because this is the, I guess, the typical or characteristic ear finding that can be associated with CHARGE. And it's this, this snipped off appearance of the lobe. Not all children with CHARGE are gonna have this, but again, something to consider if you see an ear that looks like this, that it's pretty unique. And then here, a child with CHARGE who has a facial nerve palsy, which is not part of the original acronym, but again, is a characteristic feature. And then something that, it's another syndrome that you may or may not heard of, but with colobomas, a condition we think about is cat eye syndrome, and it's caused by tetrasomy or duplication of 22q11. And they can have iris colobomas, ear anomalies, and anal anomalies. And then other conditions include chromosome abnormalities. It's been reported in 4p minus. I've seen a child with Noonan syndrome with a coloboma, but there are other conditions including kabuki, brachioculofacial, and renal coloboma syndrome and Aicardi syndrome. I think that is that. So I know that's a kind of a lot to review. Just kind of went through it fairly quickly. But if you guys have any questions, let me know. This was really just an overview of ways to think about birth defects and remembering that these can be isolated or part of a genetic condition. They can be sporadic or multifactorial, or something that's following a Mendelian pattern of inheritance. Okay. If you don't have any questions or comments, we can call it an afternoon. I can hang on for another minute or two if anybody has any questions. All right. Thanks, guys. Have a good afternoon.
Thank you.
Thank you.